Today I'm going to talk about knee pain. First of all, we have to know what osteoarthritis is, and it's basically a degenerative bone disease that causes the cartilage to break down and wear out. And we don't really know why it happens. There are several leading causes of it, but it's happening everywhere. And in the U.S., about 46% will develop osteoarthritis in their knee. There are different types of arthritis, but we'll be focusing primarily on osteoarthritis today. Certainly there's a disease progression. Some of you may have it early, some may have middle or mid-stage, and some may have severe. Certainly the early stage is more in the younger population, 20s and 30s, primarily sports related, and it affects just a small portion of the knee. And I don't know if you can see, it's a little bit hard, but on the far right here, just a very, very small area on the cartilage can be damaged. As the cartilage continues to wear out, then there's increased pain and reduced mobility, and you see here how the lesion gets bigger and bigger. It can really start affecting your activities, whether it be daily activities or sports-related activities. And there's some options for treatment on that, and we'll talk about those later. As it gets more severe, and that's when typically folks come in to see us, is it's involving all areas of the knee. And we break the knee up into 3 different spots. And so when it gets into all 3 areas, we call it tricompartmental. And it's usually with severe pain, difficulty with walking, your tolerance to doing things which normally would be simple everyday activities is pretty much gone. So that leads into then, what are the treatments? And you'd think that I'd say, well, the only treatment is surgery, and that is definitely not the case. And we give everybody the opportunity of non-operative treatment and keep your knee as long as possible. And those things can include, but are not limited to, certainly weight loss or getting going with some therapy, doing some anti-inflammatory drugs, whether they may be Motrin or Aleve or Tylenol, and then changes in activity, avoidance of those high-impact things that can accelerate the problems. And then if all of that fails, then perhaps surgery is something that could be considered. And that's something that is part of the visit with us. We're going to talk about what do we do first, what do we do next, and here's our plan afterwards. So if we go on then, what are the surgical options that are possible? And that's of course after you all have failed or the patient has failed non-operative treatment. And if it's an early sports-related injury, we may be doing arthroscopy, tiny, tiny holes, the camera goes in, we shave and smooth the cartilage, maybe drill that area of the bone and help try to get some pseudocartilage to come back. As it gets more and more involved, then we have this partial knee replacement or partial knee arthroplasty, where parts of it can be replaced if not all of it is damaged. And then finally total knee arthroplasty, which probably most of you all have heard of. So we're going to focus a little bit more today on the partial knee because that's a bridge to hopefully allow everybody to have a well-functioning knee no matter what your age. So knee surgery may be suitable for who? Those who are in that late stage of arthritis, severe debilitating joint disease. So you get up in the morning, it's stiff and painful and achy. You maybe take some anti-inflammatories, kind of get through a little bit of the morning, and then by the afternoon it's again hurting you. You have imbalanced problems and weakness. So those things are not likely to receive or have good satisfactory results with non-operative treatment, so it may be something to consider. First, of course, is the total knee, and that's something that's done very, very frequently. It's one of the most successful procedures in orthopedic surgery, and it basically is considered still the gold standard because most people don't come in early and just say, well, I can treat this on my own for a while, and by the time we see someone, they've already have it in all 3 areas, so it's advanced. But the survivorship is very, very good, and it really depends on the patient's age and their activity level and how well it's put in. So those 3 are very, very key. But if we look at how it's done, first we have to know what it looks like when it's normal. So this is a normal knee, and you see the cartilage surfaces are here, should be very, very smooth on the femur and tibia. And that's what you would see on the inside. If it's starting to be arthritic, then it becomes diseased and damaged. It's very irregular. The cartilage starts to flake off, and you may even have pieces that are floating around and hamper the mobility of the knee. So when it's replaced, all that goes away. Just a very few millimeters of bone are taken off, and then in replacement is the metal on the femur, the metal on the tibia, and in between is the plastic that forms the smoothness of the joint. If you were to look at a knee x-ray, this would be somebody who has a very, very normal knee, hopefully no knee pain at all. And you can see it looks like there's space in between, but in fact, that's the cartilage on each surface that I showed before. If that's gone, then you have this, and you see this is the typical bone-on-bone of a knee that's been quite significantly affected with arthritis. What we see a lot too is that this person then has also a bow-legged deformity. That's not from being on a horse for 35 years. It's from having cartilage loss in that area, and it affects primarily this side of the joint. So when it's replaced, this is how it looks on the x-ray. You see again the metal component on each side. There's plastic in between, and when you look at it from the side, it fits very, very nicely, and hopefully that's a good result for a patient. This is basically a little video about what it looks like on the inside. So that's the arthritic knee. You see how it's very damaged. The bone cuts are made so that it fits right on the implant. See that very nicely. And then typically we bond it to the bone with a type of a polymer glue, and then that goes together, and then that's now the new smooth knee. So the arthritis in the knee joint is gone on that one. Patients always ask, is this ever going to come back? And it's not. So the knee arthritis is gone, and replacement solves that. So if we go into what's new, companies and surgeons are always looking for ways to improve things that have been done. The plastic in between has been something that's studied a lot and improved over the last 15, 20 years. But now we're getting into a few more things more with computer assistance. So these are two technologies that we're using here that I think will be very, very helpful. The computer navigation is something that is in the operating room that helps to align the implants better and more precisely, and that will help affect the form and function of this joint. And I'll show it to you here what it is. Basically, it's like having a GPS in the operating room. So there's some infrared cameras that look at the knee joint, that then we put in some parameters of the knee joint, and it will show us to within a degree how close it should be done. So these infrared trackers, they're comparable to satellites, and can monitor or locate the markers and instruments, and then we collect that data and then implant that so that it's just put in perfectly with your joint. This is what it looks like. Some of them are hardwired into the operating room, so we have the lights, and with the cameras associated with that, we have the computer based there as well. Some of them are portable. Ours right now is portable that you can bring in, and the camera is set up, and you see these are two little cameras here, and they track these different monitors that we're using, all in an effort to make this precise. And here's what we see on the computer. There's some numbers here that shows the alignment, so we get to within 0.1 degrees of accuracy with the computer navigation. It allows for fine adjustments and correct the positioning orientation of the implant. Everybody's femur and tibia and patella are just a little bit different, and how everybody walks is just a bit different. So if we can correct for that and make it nice and perfect, then we know that this implant will last longer for you. Partial knee surgery is something we'll also talk about, and what this is, again, is just targeting in one area of the knee, sometimes two. It's definitely less invasive than regular knee surgery because the incision can be smaller since we're dealing with only part of the knee. And it's somewhat limited. Not a lot of people have it because you don't come in time, or if it's progressed so far, we would need to replace the whole knee. So that's something that we would talk to you about in the appointment. What we're using now is a type of a system that involves a robot, and it's called the MAKOplasty. And basically what it is partial knee surgery with robotic assistance. We're still doing the procedure. The robot is just there to help with precision. And basically it makes it minimally invasive, and again it's surgeon controlled, and it allows for accurate resurfacing of the area of knee that's involved. And so you can see here, if we're looking at just one section of the knee is being replaced. So we come in and we burr down this area, or we can do it on the top part of the knee, or we can do it on the outside part. And so doing this then preserves the majority of the knee if it's still a good knee. Obviously, if the whole thing is bad, we wouldn't be doing this procedure. And this is what it looks like. It's basically a handheld machine, and we're actually holding on to this, and this is a high-speed burr, and that comes in and goes down onto the knee. It's controlled by our hand, but we're using the help of the CT scan before to really make sure that the accuracy of that implant is put in properly. So here's what it is. It assists the surgeon. It's patient specific. So what we do is we send the patient to a CT scan before, and the CT scan looks at your leg from all the way to the hip, all the way down to the ankle. And then it takes those images and makes a whole new knee on the computer. It looks like your knee on the computer. And then we do some preoperative planning and balancing so that we know where to make these cuts and know where to make the burring. And then once we are there, then we would take that, your knee is opened, and then we make some burrs and some marks on it, and then that implant goes in. So it's definitely us still controlling it. The robot just helps make it very, very precise to put the implant in position. The good thing about it is we're not removing really any ligaments. The main ligaments on the inside right here are still preserved. So it still feels like your normal knee. The only thing that comes out is the bad cartilage. And this is what it looks like on the x-ray. You saw the x-ray before where the whole knee was replaced. Now it's just this portion. So you can see on the before x-ray that this is the area of involvement. See how it's getting narrowed in that spot? Now this is the new implant that takes that place. The rest of the joint is preserved. You look at this patient, this is abnormal. You see how very tight it is. The cartilage is bad. They also had bad cartilage under the kneecap. So those two areas were switched out and replaced in that patient. But the nice thing is it still feels like a regular joint. We don't remove the main ligaments, and the incision is much, much smaller as well. There are a lot of benefits, and I've talked to you already about that. It is certainly a much smaller incision. Only the arthritic portion of the knee is removed, and the implants are optimally positioned. This knee implant has been around for a long time. Many companies have made partial knee replacement. And the results sometimes aren't that good because you can't put it in perfectly all the time. So if the alignment is just a little bit off, instead of it lasting 5 to 10 years, maybe it only lasts a year. Well, that doesn't really help much. You got to come back in a year and do a total knee replacement. So with this, it's very, very precise, and hopefully you'll allow yourself to preserve that knee a little bit longer. So there are all the benefits, as we said. A little bit better on the on the recovery, because the rest of the knee has been preserved. So quicker in and out of the hospital and less pain as well. So who are the best patients? Who are the good candidates? Well, it's knee pain with activity, typically on the inside of the knee or under the kneecap. Startup pain, like I talked about, stiffness, just that feeling of achiness in the morning. And then, of course, failure to respond to non-surgical management. And of course, that's going to be a decision that you'll have to make along with your surgeon if you're ready for something like that. The results have been great. It's shown that using this type of system has markedly improved that patient's success with the partial implant from previous. There's been some 5-year data that has come through that looks very, very good, that this is, I think, much more beneficial than just the old way of doing it. It's basically, and I think even the guy we work with a lot, he's standing here, he had a good way of putting it. He said, the computer navigation is like your car, where it has the GPS and tells you where to go. The robot is more like you program into your car and the car is going to go on its own. You're still there, you're still programming the car, and that's where it's going, right? They're going to eventually have us not even touch the wheel because it'll be a lot safer. So that's kind of what the robot is for us. All right, thank you very much. Appreciate it.